Hey everybody, we're back.
Woohoo.
Welcome to the Munch Bunch podcast. My name is Kimi Nishimoto, myofunctional therapist with my awesome myo bestie, Megan Van Noy.
Hi guys.
And today we have our awesome guest, my Instagram friend, Dr. Tara Erson. She's got a practice in Las Vegas called Smart Mouth. And we're going to let her introduce herself now.
Thank you so much for having me. I'm really excited. So let's see, 2018, 19, just about 4 years ago, I quit doing regular dentistry and decided to try something new. I had been learning a ton about tongue ties, and there was not a whole lot of other people in my area treating them the way I thought they should be treated. So I thought, go big or go home, and I wanted to try and create kind of the optimal gold standard model where I include kind of all the pieces of the puzzle in one roof. So it started there, and over the last 4 years has grown, and now I also do early intervention expansion, and even some adult airway stuff. So we're kind of turning into birth through the lifespan airway type issues.
Yeah, I love that. It's so it's so hard when there's so many pieces of the puzzle. And so it's great to have a practice like yours really start to encompass all the different pieces, right? Because how many times have you had a baby come in and then they're like, oh, what about my older kid? Oh, wait, what about my significant other, my husband or my wife? Or, they start like poking each other in the ribs, like, this is you. So I think that's so great. What kind of inspired you to start that way? Like, how did you learn about tongue ties? Like what kind of got you down the rabbit hole that we all now live in?
I graduated dental school in 2012, and then a month later, I had my first child.
1 month?
Yeah, so I was pregnant in my last year of dental school.
Oh, girl.
It's amazing.
I kind of had decided that I wanted to take a year off, like just not start practicing dentistry yet and really focus on being a mom. I was really excited for that. And so I was very active in the lactation community. I breastfed, and people would say, oh, you're a dentist. You know about tongue ties? And I'd go, I don't know what you're talking about. I've never even heard that word before. Like, leave me alone. I'm trying to be a mom. I haven't really even practiced dentistry yet. Like, I don't know. And honestly, it took, some people in the lactation community about 4 years to convince me that it was something worth looking into. Meanwhile, I was just kind of doing regular old dentistry. And in 2016, I went and shadowed Dr. Dahiri.
Okay, up in my neck of the woods.
Gracious enough to just let anyone come and watch. And that's really all I needed to convince me it was so obvious that it was solving a problem,
Yeah.
And so from there, pretty much from like 2017, 18, and 19, I took every single tongue tie class that existed, many classes. And it's just once you started learning about it, once you realized, and at first it was just babies, it was just breastfeeding that I really paid attention to. You meet more people in the community, like speech therapists, and it's like, what about older kids? What do you mean, what about older kids? Well, it affects this, and this. Oh, okay. And then what about airway? Well, what do you mean airway? Like, I'm just talking about breastfeeding and speech and solids. So it was a really cool transition. And I think it was the moment where I learned that our tongue actually grows our face. If it's up in the roof of the mouth where it belongs from infancy through growth and development, and my head kind of exploded.
Yeah.
So that's why so many people need braces. And that's why your teeth move when you get your braces off, because you didn't fix the root cause of why they were crooked in the first place. And yeah, I mean, that literally changed the path of my career, because it's too important. And I had never heard of it before.
Yeah. Yeah. And we get that question a lot from patients. Well, why don't dentists know about this? Why don't ENTs know about this? Why doesn't anybody know about the tongue or look at the tongue? And I always kind of liken it to, like, we don't, like, as Western medicine, we don't study the body as a whole body. Everybody kind of has their responsibility. And then we have to, like, fill in the pieces in between. And, that's kind of what myofunctional therapy or facial myofunctional therapy, however you want to call it, lactation consultants, that's where we kind of piece into the puzzle so we can all work really closely together. So what is your practice kind of evolved to now? Like, what are you guys doing? Do you do any, run-of-the-mill dentistry anymore?
No.
Yeah, out of that scope.
I will say that, I started doing this because I had little kids. I was only working 1 to 2 days a week anyway. And so it wasn't a hard leap for me personally to say, if I only need to work 1 or 2 days a week, I'll just focus on this stuff. It has turned into like 3.5, 4 days a week, which is about the most I'd like to be working with my 3 young kids. But yeah, so I jumped headfirst into the idea to see if it would work. And my biggest thing for the tongue ties was I have a massage therapist, internationally board certified lactation consultant, and an orofacial myologist, all on staff. I'm not with them. I'm not contracting with them. Like, we are a team. We all have the same goal, and we work very cohesively. The only piece I'm missing is an SLP, the speech language pathologist. But I have some really great people in the community that I work with.
Yeah, that's like the dream team, because we always say, therapy, body work, then release, and then more body work and more therapy. So that's amazing. I was telling Dr. Tara before we started that her practice is like every airway dentist's dream that they think that they're going to do, and they actually never do.
Yeah.
Is to have like a tongue tie center and also all the pieces together.
When I talk to dentists about what I do or when I'm teaching, I try to be really transparent that my goal was, like, in those early years of being a dentist, was never to make money. Like, I was busy being a mom, and I just wanted to kind of keep my hands in dentistry until I was ready to commit more to my career. And so that transition, again, was easy, because there wasn't a lot of stress on me that I had to make it profitable immediately. And I got to the point where I was just convinced that this was the future and it was a good choice and I would get there eventually. And it took a long time, and we're still just kind of very slowly getting there. But I think it did come through. Like, this is what is important right now in healthcare, the up and coming.
Yeah.
So I'm really glad I, took the leap.
Yeah.
Yeah, absolutely. Well, something that I know a lot of our listeners struggle with, and a lot of parents talk to us about, is how difficult it is to navigate having kids that you want to have assessed. Some people are really expansion focused. Some of them are like, the providers are like, no, wait till their permanent teeth come in. They're too little to do anything when they're 3 years old, or it's just very provider dependent. So what would be your advice as a dentist on how to navigate that for parents? And what would you suggest for like the average person who's trying to help their kids that have sleep disordered breathing?
Yeah. And like the ages too, like the ages to look for these things. That would be really cool.
So, it's something that I see every day in my consultations where the parents come in and say, 3 people have told me this, or 3 people have told me 3 different things. And then I say, well, I'm about to tell you a 4th different thing. And, I think I do know what I'm talking about, but the parents don't know which person is actually the person who knows what they're talking about.
Right.
What I would say, kind of the most generic way I can say it, is this has become a world of specialists. Generalists are not really who you need to go to when you have these very specific airway or tongue tie type concerns.
I think it's a really good point.
It does require some harder work from the parents. I just know that, you want to be able to just say, like, I'm going to go to my local kids dentist and ask them because they're a kids dentist, or my pediatrician, or my regular dentist, or my orthodontist. And unfortunately, I wish parents understood how generic our educations are. We graduate with the bare minimum knowledge to do the most basic stuff, right? Dentists fill teeth, make crowns, deal with cavities. Orthodontists make teeth straight. Pediatricians avoid a disaster, right? As long as your baby is growing and surviving, like that's kind of the bare minimum. And so, a website, word of mouth, Facebook groups, you really have to do your research to find someone who is talking about the things that you're interested in. I mean, I try to help people all the time find resources in their area. And sometimes I know them, people I've met in classes, and sometimes I have to do a little digging. And if I see a name pop up and I go to their website and their website says nothing about airway or nothing about tongue ties, I'm like, okay, is this just something that you say you do because for whatever reason, or is this something that you are an expert in, that you've become?
Yeah. And I feel like it's hard because I don't know why. I don't know if it's just a dentist thing or what, but I feel like nobody updates their websites anymore. Like they specialize, right? And then they need to like update their website and give like the latest, and they really are doing these things. So then you have to call the office and does their front office know the keywords, right? Like, and feel like
it just puts a lot of extra stress, I think, on parents to really, I mean, hopefully you're in an area, I know that Facebook has a lot of cons, but one of the pros is, finding the local groups that talk about this kind of stuff. Once someone is in the know in the way you want them to be, I'm sure you've seen that they're like your biggest cheerleaders and advocates, and they'll explain it to people the way you want it explained. I don't have, I honestly think Facebook is probably the easiest way to just try to find word of mouth. But I have seen a lot of great websites that take the time to explain why people do what they do and how they do it and what they've learned. And you can tell often the passionate ones from the ones who are just trying to add another procedure.
That's so true.
I think finding orofacial myologists is also a really good first step, because that is technically the only, profession that should be all on the same page with this stuff. At the very the airway is important and tongue ties matter, and what your tongue is doing matters.
Oh yeah, we scream that from the rooftops.
So, the orophacial myologists who are doing this regularly, they should know who the ideal providers are in the area.
Yeah. Finding someone, and then again, do they have a website? Are they again word of mouth? Or it's hard to navigate for sure. So, what age for you, kind of in your practice, are you starting to even evaluate as far as like the oral space, the tongue space? All the time we say tongue space, tongue tone, tongue tie, right? Everything has tongue in it. But, when do parents need to start looking for those things? What can they really what are some red flags they can look out for to start working, especially on that tongue space piece of the puzzle?
So obviously the sooner the better. If I try to tell, referral sources, get them in my office ASAP. That does not mean that they have to commit to doing a procedure or that it's even the right time to do the procedure. But if we can get an evaluation, we can get a game plan going. One of business-wise, something I'm terrible at is I send probably more than half of my consults away. You need therapy first, or you need an ENT first, or you need expansion first, or, there is a lot to be done before a tongue tie is the right thing to do. So, okay, you've gone through infancy. Toddlers are really hard.
Amen.
There's not a whole lot, really any profession can do in that toddler age. There's some big fires that you can fight, but there's not a whole lot of prevention just because they're not compliant. I love the Myo Munchee.
So do we.
Oh yeah. Isabel's turning into a toddler. She's just like 3 weeks shy of turning 1. She's turning into a toddler. She's been getting into her BB munching more and more. I know she has, and sticking her tongue out and all those things. So I do fake baby Maya with her, because we can only do so much.
I feel like Myo Munchee is probably the only tool, for that 1 and 2. But 3, I think that a lot of 3-year-olds could start some kind of expansion. That may be more of like a Myobrace type situation, which is more of a trainer, early intervention. But I actually learned something called ALF. Dr. Derek Nordstrom. It's a very, I think I even have.
Actually, Tara, we had a whole 2 podcasts about ALF. So
yeah. One of our doctors in California who worked a lot with Derek Nordstrom gave us some really cool cases.
So
so little. Yeah, it's so good.
Minimal, right? There's a color. And so it's usually well received, well tolerated by these kids. Taking them in and out is the hard part, but they're well made. They tend to stay in. And it's a slower type of expansion. It's a more complex type of expansion. But when a 3, 4, 5-year-old has them in, amazing things happen because their face is growing. Right? So it's working with the body rather than waiting until the face is done growing and then trying to shove it into some configuration.
I think that's a really good point because we know that the face does a lot, the mouth and the face does a lot of the growing by the ages 4. So that's awesome because a lot of people won't even touch a 3 or 4-year-old for early intervention.
Because it's a pain in the butt.
The pre-cooperative age group. And they bite hard.
Long care time. Lots of negotiating and begging and playing, and it does not fit well in a fast-paced, money-oriented type practice.
Yeah.
And
I don't think I realized you could do ALF that young. That's really cool. Not that I knew that there was an age group, but I wasn't even thinking that you could do an ALF as early as 3 or 4. That's amazing.
Yeah. So as soon as they get their second baby molars, then the next step is they have to be able to sit for either the impression or the digital scan. I invested in a digital scanner specifically to help 3 to 4-year-olds because you can take lots of breaks, rather than the ooey gooey yucky impression that most 3-year-olds aren't going to tolerate.
I can't even imagine.
No, there's barely adults and teenagers who can tolerate that.
It's over and you have to do it all over again.
Oh, yeah.
I think the youngest one I've started was probably like 3.5. But it's cool. It's cool to watch how quickly they move. And I'm very transparent with parents. It's like my goal is not picket fence perfect teeth. Like my goal is to make room so that the adult teeth have the space to move in. And bodies are weird. Everyone's different. Everyone has their own bodies have their own reasons for doing things, really good reasons, and we can't always figure that out. So it can be unpredictable, but no one's ever regretted trying something. A parent who's worried about something isn't going to regret trying it.
Definitely. Yeah.
We make less improvement than we hoped for. Well, that was still more improvement than would have happened otherwise.
Than where we started. Absolutely.
And you mentioned this product, but I wanted to see if you could go into it a little bit. What is the Myobrace and what is it used for? What is it good for?
Well, can I show some slides? Because
Absolutely.
Ooh, please. Yes, please. Yeah. Because we've talked ALF, we've talked Myo Munchee. We know Myobrace is another one a lot of people ask questions about. So anything you can give us, we love.
Woot woot, Myo Munchee.
There it is.
Megan and I are both Munchee ambassadors.
Yeah.
So can you see that?
Yep. Oh yeah, you're good.
So Myo Munchee, they have ones for as young as, technically they say 6 months. I don't know a whole lot of 6-month-olds that are, gonna use it.
Nah, is he kind of just chewed on the side of it for a bit?
They can start playing with it. They can start just mouthing it and getting comfortable with it. The big thing about the Myo Munchee is you actually have to use it, right?
Yep.
I mean, it's not just by buying it isn't gonna fix anything. And I am the worst at creating routines, not only in my life, but in my family's life, right? So this is challenging for me, and I don't want parents just buying it and then being disappointed. Like I do spend a lot of time talking about how you have to create the routine. You have to use it every day. Otherwise, you're not going to do a whole lot.
Consistency.
I tell them that when they've done 3 months of regular use, that's a good time to reevaluate. If you're seeing good change, that might be all you need. Like that might put you back on track to good oral facial development. If you do 3 months of daily use and you're really not seeing many changes, then you're going to need to kind of take it up a notch and do something a little more powerful.
And for our parents out there, my very favorite thing to recommend to parents is have them use their Munchee in order to earn screen time. So if they want to watch TV, or if they want to play on the iPad or whatever, Like you have to use your munchie if you're going to be on there. And that helps compliance so much. You'll get like 20-25 minutes worth of munching on that thing. And so any parents out there, great tip for you right there.
Yeah. If you're screen time users, or another time is at night before bed, keep it by your bed. And when you read your books, we're munching while we're getting read too. Or dance parties. That's another fun one. Any dance party is always munch.
So I say it's the cheapest, most do-it-yourself way to get started down this path if you're just trying to, while you're trying to navigate everything, get a munchie. Get one for yourself, get one for every person in the family, do it together. It's only going to benefit you. Myobrace, I think, is kind of the next step. I do not use Myobrace kind of the way they market Myobrace. I use it much more as in a way, as I wrote here, like as a night guard. I mean, you can't, a lot of kids are grinding. That's an airway issue. A lot of parents are like, can you make my kid a night guard? No, you can't. It's not like it'll hold back growth because you're like holding things in place. B, you'd have to make a new one every 3 months because you're constantly like losing teeth, moving teeth. C, they probably won't keep it in. So if your kids are grinding, this can be a nice option because it is going to protect your teeth, but it's also going to do a couple of other things. You wear it while you're sleeping. It is going to do a little bit of arch development. It does help you remember where to put your tongue. You have to breathe through your nose while you're wearing it. There are some good things about it. I think there are definitely people who've kind of done their research and they show up and they're like, we want to try the Myobrace system. It's like, okay, I mean, let's talk about everything, but that's fine. I just think for the most part, if you're to this point, it might just be easier to go straight all the way to expansion. But again, and then finances are part of it sometimes. Like obviously it's much cheaper. So
yeah, multifactorial.
It's a cool product for certain situations. I don't know a whole lot about Healthy Start, but it's very similar.
Yeah.
So it basically just becomes, what does your provider, what have they learned? What do they use? I'd say they're about the same. This one's kind of cool. I actually have a little girl. She's in ALF, but there was one tooth that wasn't really coming out of crossbite, and the parents started having her wear the froggy mouth while she was doing her homework. And mostly the crossbite was because her overactive lips came back on the teeth. And so this makes you swallow more properly. And it's cool. Again, these kind of gadgets, like, you have to have the right situation. They're too expensive to just throw at everybody.
Woo! We love REMplenish.
Yeah, we're buddies with Anders.
It's cool. I have a
little video. That's awesome. You can see it though. Look at that. That's cool. That's a cool side visual.
So it's just, again, we throw all these products at people. You really have to have a basic understanding of like why it matters, right? Like we know that when you swallow, you're only supposed to use your tongue and then see some movement down here in the throat. And most people do a very using their lips and their cheeks and their tongue all incorrectly to swallow, and that's wrong. And again, I mean, it's kind of an expensive gadget, but it's cool. I like it.
It's fun. Yeah, it's just another tool.
Expansion. I talked about ALF. This is what I use more for 7 and up. Mostly that's just my preference because I don't have as much experience yet with making the ALF be effective enough to be worth their time and money for the older kids. Because again, a lot of your growth has stopped. It's just my skill set isn't there yet. So three-way Schwartz is just the name of this type of appliance that has acrylic plastic and pushes in 3 directions, meaning, left, right, and forward. And you turn the little screw. Many orthodontists will use something called a rapid palatal expander. That simply goes left and right. It doesn't go forward.
Yeah. That's what I had in middle school.
The thing I don't love about it is that it takes the tongue space, right? And so again, you have to be, there is no one way to do any of this. Every case is going to be different, but it's definitely important to think about. There are kids where I'm like, don't even think about Myo right now. Because you need to be wearing this 24 hours a day. You literally can't do what you need to do properly. So you are desperate for space. Let's get you some space. And then we can start talking about the rest of the big picture.
That's a really good point because I tried in my old Holly retainer, my acrylic retainer with the wires and stuff. It is impossible to keep your tongue in a suction against it. You just can't do it. But sometimes at this age, when they're young and they're growing and you need to use that growth factor, you expand them and then we do Myo later.
Yeah.
It's just about being flexible. There's no one way to do it. And then there's this ALF. I don't have, this is a post picture. She was in a complete crossbite, like one side completely over. And this was just like an actually really easy, fun case where I just kind of plopped those ALFs in and adjusted them every 6 to 8 weeks. And she just opened up beautifully. Room for all of those adult teeth.
Look at all that space.
This is a space where it's like, this might be it. Solve the problem.
Such a rare picture of a kid to have a palate that's not way high and vaulted.
Right. I had good bones to work with too, but her speech improved and she slept better, and it was just, this was
all the good stuff. Yeah.
Not all of them are that.
I bet she wanted to get that little buckle tie right there.
Yeah, and that's the thing is, she's very nervous about a tongue tie release. This is without a tongue tie release. She worked really hard on her Myo. And again, you just kind of have to meet people where they're at. She wasn't ready. We got people. So
I think you just made like such a huge point, and kind of something that I feel like I've been running into a lot in these past few months as within treatment is meeting people where they're at is just so important. Like that's what we really do. And that's what we really focus on in our practice. And then sometimes when we refer out and we try and collaborate, a lot of times patients are being thrown so many things and they get overwhelmed. And we need to go with the patient and where they're at, get the feedback and move them in steps. So I think that's really great that that's your approach is so meeting people where they are instead of trying just to overwhelm them.
Yeah. And again, I think it's back to that idea of this, any improvement is better than no improvement.
Amen.
So let's focus on that rather than trying to be super dogmatic, all or nothing.
Yep. Yeah.
Another thing that I'm not super personally familiar with, I do refer a lot of my adult consultations to Vivos providers. Again, it's unpredictable, and it's unpredictable in ways, you literally kind of have to do it and see if it works for you, because it has the investment. But I mean, I've seen it work. I've seen it improve people's lives. So I'm just glad.
Yeah.
I'm glad that there are these options, right?
Yeah, exactly.
And then I threw this in here. I think this came from a slide for pediatric residents that I did, but I think these are questions parents could think about.
Absolutely.
If you're going to go talk to an orthodontist, you could think about these questions. Because the vast majority of professionals are not learning specialty things about airway or tongue.
Yeah, let's read through the questions. So, and Dr. Tara put up some really great questions here, you guys. So when you're going to see your specialist, when you're going to see your providers, when you're looking for these people, like people want to know what questions should I be asking? This is a great list. So first one on here is, why is there a once per lifetime insurance benefit for ortho?
I think that says a lot, right? About what we expect to happen after we have ortho.
Yeah. And like, how many patients come back, or how many patients are listening? How many times have you guys had ortho? How many times have you had braces? My patient record is 5.
Personally, 3. Yeah.
Yeah, you're 3. Yeah, that's the record I've heard is 5. A guy in Germany, like, bless him, everything's coming together finally. But why don't the teeth stay where they're put after braces, right? Like, why do I always have to wear my retainer for forever?
So one of my favorite analogies, or just things to say to patients if we get down this rabbit hole, is, what is the end stage treatment for sleep apnea? It's usually the old rich guy who's feeling terrible, doesn't want to wear a CPAP, and so he's going to get maxillary mandibular advancement surgery. They're going to cut the jaws, they're going to move them forward, and they're going to pin it all in place. Why? Why do we do that? Because moving things forward opens the airway, right? That is an accepted treatment for sleep apnea. So then we go to the orthodontist and they put on headgear and they pull everything back to make it look pretty. And then they try to say that it doesn't affect the airway. Can't have it both ways,
It gives us rage too, Tara.
What? Yeah.
It gives us rage as well.
They're going to pull teeth and make anything smaller or farther back bad run, not good. Okay. You want to make room. You want to bring jaws forward. If you have a huge, most people call it an overbite, right? Where the jaw is out. That does not mean this is too big. It means this is too small and that needs to come forward.
Yeah. Yep. The lower jaw needs to come meet it.
Real pretty and tight. They're both too small. They both need to come forward. So just, again, it's not common knowledge for some reason. No. I don't know why.
No, it's really not.
Why are we waiting to address malocclusion? Oh, I know. I already said, because 3 and 4-year-olds and 5, 6, 7, 8, 9, they're pains in the butt. Like, the compliance is poor. They lose their appliance. They break their appliance. They take a lot of time in my chair. They're not super profitable. And I truly believe that's why. Insurance kind of is king, and they're going to dictate how much time people have. And it's why I do fee for service in my practice, which is a luxury, right? I do whatever I think is great.
Yeah, we're fee for service at Faceology as well, because we don't want insurance to dictate what patients can and can't do.
And that's really hard for patients to understand, I think. Well, I want to go to the guy who takes my insurance.
Yeah, and then you're going to end up coming to us later.
Think about the value. Think about what we offer and why it's important versus just kind of the bare minimum, right? That insurance is going to cover.
Yeah.
And again, a similar question. 80% of upper jaw growth is complete, and you haven't even seen an orthodontist yet. They don't even want to see you yet.
Yeah, let's say that again. 80% of the upper jaw growth is done by ages 6 or 7. 80%, a B, almost there.
Yeah. And so really before that is when you want to start addressing these things. And so let me,
yeah, I think those are great points. I think those are great questions to ask the orthodontist. Those are great things to even like just look for and keep going to. So, ooh, perfect. You got some pictures for us, some cases. I love it.
so yeah, let's just kind of talk about some things that you might see in your, I mean, again, if you're watching or listening to this and you're probably going to look at your own kids, and I'll give you some ideas of things to look for. So, I actually forgot to write grinding also on here. So you can see little chips on the teeth. Can you see my cursor?
Yep, we can.
Yeah.
So you see this is super flat, little chips in the teeth, little chips down here. Look at that canine, completely flat. This kid has been grinding, okay, and grinding a lot and for a long time, and he's only 5 years old. What a class 3 means is that the upper jaw is smaller in a forward direction than the lower jaw. So I could stick my finger, down, and the lower 2 teeth would be in front, and these 2 are behind.
So future underbite situation, or like edge to edge.
Call an underbite, and you can see his tongue, right? Like that's why, because his tongue is always there, just kind of pushing on the bottom. Nothing is pushing on the top, which really, really needs things pushing on it. So. Another class 3.
Oof.
Oh, buddy.
Right. Yeah, that's a mess.
So many things.
Yeah.
The other thing too, and Tara, you're probably gonna say this, is like, look how like close all those baby teeth are together, and then look at those bottom 2 teeth and how big they are compared to the baby teeth.
Right. And we'll see some good examples of that too. A class 2 means that the upper jaw technically is bigger than the lower jaw. It's funny because a tongue tie can cause both of these. It just depends on how the patient or the child uses their tongue and their facial muscles. A tongue tie can almost be like an anchor and hold that lower jaw back, right? It can also just keep the tongue low so that it's never touching the roof of the mouth and we don't get that upper forward growth. So hers is very pronounced because of the thumb sucking.
And for our listeners who aren't watching the YouTube, basically this one looks like a pretty big overbite and what you would call, quote, buck teeth, where the upper teeth stick out a lot and the bottom jaw is way far back. And then the top teeth almost look like they're curling inwards to try to fit together.
And that's the thumb is kind of deforming the roof of the mouth, and then the cheeks from the sucking are squeezing in and making it more narrow and
making it all collapse.
So class 1 in dentistry means the jaws are the right sizes. It means that they're the right size in relation to each other, we should say, because almost all are actually too small. I mean, literally like 1% of patients with teeth that walk through my doors have jaws that are big enough naturally.
I know it's a scary epidemic right now.
You might look at this and say, there's spaces. I mean, it looks fine. But look at that grinding. This is not a happy airway. Also, we call this a deep bite. And this might be a little hard to describe, but the the top two teeth are almost completely covering the bottom teeth.
Mm-hmm. Yeah.
So really what is happening here, this is where a lot of gummy smiles come from. The upper
We get that
jaw,
question so much. So like really highlight this.
yeah, so your upper jaw, it wants to grow forward, right? It wants to get bigger. So there is just a, what am I saying? Like a program to grow. But if the tongue isn't up there, what happens a lot of times is you get downward growth. And so the upper jaw literally gets like longer instead of farther forward.
That's a great explanation of gummy smile.
So good.
Let's go back. So yeah, so this is a good example of that. Maybe he'll have room for all of his adult teeth, but he's going to have a gummy smile, and he's still going to have an airway issue.
Mm-hmm.
So he's an expansion, and I'm glad that his parents understand the importance of that. Because most people would look at this and say, "Oh, you have such a nice smile." Again, so this is what you were mentioning earlier. Again, this might be someone saying like, "Oh yeah, I mean, I see some spaces. There's no overbite, underbite. All the teeth fit together." Don't forget that adult teeth are like 50% bigger than the baby tooth. So how am I going to fit a tooth that's 50% bigger than each of these and have room? I'm not.
And from a hygiene perspective, because Megan and we were trained first as hygienists, that kid's going to be more cavity prone, and you can see orange stain and plaque on their teeth and decalcification in between them.
Yeah.
So. Yep.
So yeah, this is considered crowding. If your teeth are touching, if your baby teeth are touching, you're crowded. Period. So technically, in terms of jaws, this is a class 1, meaning the relation to each other is right. But for whatever myofunctional reason, he's got a crossbite in the front. The top teeth are behind the lower teeth. Also super narrow. This is a child with Down syndrome, and we got an ALF in there.
Wow.
So
that's amazing.
Hopefully we can make an improvement,
And with Down syndrome, aren't they really prone to having congenitally missing teeth?
Yes, and also low tone. So there's a lot of challenges there, but I think, again, like, why not try?
Oh yeah, anything we can try, anything we can like take off the table later, right? Like maybe we get some expansion, so then when this kiddo is older, they have a better chance at breathing better.
Right.
Just
severely crowded.
I can't believe that's a 9-year-old's mouth.
Right.
Yeah.
I know.
Oh, buddy.
So narrow.
And
the funny part is, it's like they don't look crooked, right? Like they don't look super crooked. And you just wouldn't believe like how many dentists and orthodontists are like, yeah, we'll just wait till all those teeth come in and we'll put some braces on there. But this is not a healthy airway. There is no tongue space in there.
It's like Dr. Liao says, 6-foot tiger in a 3-foot cage. Like your tongue is too big for your mouth. It's like a chihuahua mouth.
Like a one foot. Oh my gosh, buddy.
So crossbite. A lot of this stuff, the argument is there isn't studies that prove that they're related to airway issues or whatever, blah, blah, blah. Okay, that's fine. I mean, I won't argue with those people, but there are studies that say that crossbite is a very high indicator for sleep, which we know if you map out why that's an indicator for sleep. That basically proves all the other situations as well. I mean, it basically comes down to low tongue posture, poor palatal expansion, small airway, stuff like that. But clicking, sorry. So yeah, I mean, a 9-year-old, again, nobody really wants to do anything about it yet.
Blows my mind.
If I can get him out of crossbite, sleeping and breathing better, a little bit more space, he'll probably still need braces, but he'll be better off. And the other thing I tell parents is you won't have braces for as long, very likely.
Yeah, great point.
Similar crossbite.
Buddy.
Whoa. Kind of canted too, where the upper jawbone looks almost crooked.
So this is my youngest ALF patient, and she's out of crossbite now.
Yay.
So it's just it's fun. Yeah. So that's all that.
I love it. I love all those different examples of bites too, right? Because it's like maybe you only get to see 3 bites. Well, my kid doesn't have an underbite, right? Or well, my kid doesn't have, or like, well, the orthodontist didn't say, right? And it's like there's so many different examples of, you know, bites that red flags, airway issues, you know, and so now all of a sudden you might look at, you know, your own kiddo with a different lens or, you know, nieces and nephews, whoever it is, and be able to say, wait a second, I see a red flag. What, you know, now what, right?
Yeah, I had actually a consultation today where the lady was like, my friend and my cousin are both pediatric dentists, and they both said my kid doesn't have a tongue tie. They both said grinding is normal. They both said that it was, you know, that breastfeeding wasn't related, and just kind of this whole list of things. And I'm just like, I'm sorry, they're wrong. Like, sorry.
Yeah. I know. You know, I ran into it as a practitioner a lot, but now running into it with my mom lens, you know, everybody basically who wasn't specialized in, you know, tongue ties and breastfeeding, you know, looked at Isabel and was like, she's fine. And kind of like, definitely like signaled to each other that I was like the crazy new mom. And like, that's fine. I can be the crazy new mom for like other reasons, but like not this one, right? Like I won't take this one. Right. And so even afterwards, you know, and the pediatrician, I came back and I told her, I said, hey, here's the deal. This is what we went through. And instead of being like, hey, great, like, I'm glad that helped. Like, you know, I'd be interested to learn more. It was kind of like, just brush it off and was like, okay, whatever, let's move on. Let's,
like,
you know,
that, whatever.
And, you know, Isabel's was, as you guys already know from other like podcasts, very tied in all places. And, you know, she's doing awesome now. So
in all places.
And then I think it, you know, I have 3 kids. Each one got progressively harder to breastfeed. With the older 2, I didn't know anything about ties. With the third, who's 2, we joked through my whole pregnancy here in the office that he was going to be the perfect baby because we had literally every resource at our disposal. You know, I had an SLP, an IBCLC, massage therapist come to my hospital bed at birth and do evaluations and help me. I had to redo his tongue tie. I did it at 3 days old, and then I had to redo it at 6 months old. At 20 months old, I had to put him under sedation and get 6 crowns because of severe decay from mouth breathing. And now next week, he's getting his tonsils and adenoids out because they're ginormous, and he's always congested and he snores. And I literally know so much about this stuff, and it really taught me a lot. It humbled me, and it taught me a lot. I mentioned this at the beginning, that our bodies have very good reasons for doing the things that they do, and we can't always figure those reasons out. And so, as you said earlier, you just can do the best you can do, and you keep trying, and you don't give up, and you try not to cry too much about it.
But it's okay if you do sometimes.
That there, you know, the airway dentist baby frenectomy expert couldn't fix her own kid, and that's okay. Like, it's hard.
Yeah.
So don't give up, you know.
Yeah.
Keep for the answers, keep finding the right providers. It's worth it. Like, the ENT said he will have such an easier time with the anesthesia and the recovery if he's 3. And I said, that would mean a whole nother year of bad sleep. And he said, I completely agree. And I was like, can I hug you? No. But it's true, right? Like, don't underestimate how important a night of good sleep is.
True. Yeah. I feel like that's like the high note to end on. Yeah. Any nights, you know, that like, you know, I like used to, you know, didn't take advantage of with Isabel or in my pregnancy. Like, it's crazy insomnia. Like, you can just tell the difference now of like when we all have a good night of sleep and when we don't have a good night of sleep.
I love it. Thank you for sharing the story about your son, because like so many people are like, I didn't know with my first kid and now I know with my next kid, I'm going to be prepared. And sometimes it just doesn't go the way you think it does. And it's okay. You're still a good parent.
Yeah. Doesn't make you a bad parent. Yeah. Oh,
and they are lucky that you know what you know, so then you can advocate for them. So well done to you. Well done to all of our clients.
If we hadn't done anything, right?
Yeah. Or even your kid gets to 10 and you're like, I didn't know all these years. Like, that's okay now. You know now, right? Like, we're not into shaming. We're not into like, oh, well, you should have known. Like, we didn't even know 10 years ago, right? Like, you know, you do the best you can with what you got. And as we learn and we adapt and we change and we grow, like, that's where it all really matters.
I love it. All right, guys. Thank you so much for joining us. Thank you, Dr. Tara. And guys, I'll put the link in the description, but Dr. Tara Erson, she's in Las Vegas.
Woohoo!
Her website is www.smartmouthlv.com. And again, they have awesome services. They have myofunctional therapy in the office. They have body workers, aka like a massage therapist who can do myofascial release. She does cranial sacral therapy. All sorts of really cool bodywork stuff, as well as lactation consultant, IBCLCs there. So if you know anyone who's struggling in the Las Vegas area, this would be an excellent resource.
Yeah. And then Dr. Tara herself is there. Like, she'll help you too. Perfect. I love it. And of course, you guys can find us on social media. You know, the Munch Bunch podcast, Kimmy's at Mouth Muscle Memory. Mine's at NWMFT. You can always find us and reach out as well.
Thank you.
Bye, guys.